Hi, this is Alanna Bree with T4 Tots to Teens Tidbits, hosted by Sage's Diagnostics because education is part of our DNA. So, wearing my pink PJs today because we are launching Storytime with Dr. Bree through Made a Masterpiece. So, in honor of that, I have on my pink PJs. So, if you do have any patients with skin conditions that are younger and would benefit from hearing story times from Dr. Bree, please send them to the Made a Masterpiece YouTube channel to subscribe. And those story times will be uploaded on Sundays each week. We'll be talking about different skin conditions, reading books with different skin conditions, as well as books about compassion for ourselves and others. So yay to that. And then also another announcement, I am now on the line as Dr. Ali B. So go out and like and subscribe to the different social media platforms because I'll be out there on the line as Dr. Ali B. So anyway, let's jump into Fungus Amongus. We're going to be talking about pediatric fungal skin conditions. Just some of the basics. So fungus, it is a separate kingdom of eukaryotic organisms, and it does contain both yeast and mold. So yeast is typically acellular, is typically unicellular, and it reproduces by asexual binary fission or budding, which leads to pseudohyphae. And then they do have sexual reproduction under stress, which leads to spores. Molds are multicellular. They have both asexual and sexual sporulation. They have filamentous growth, which leads to the hyphae. And then when we get connected networks of hyphae, we have mycelium or the colony. And then dimorphic fungi, this can have yeast or hyphal forms, and it's just based on the environmental conditions. So those are the basics of the fungus among us. So mycoses, these are conditions in which fungus pass the resistance barriers of the body and they can establish infection. So as a dermatologist, a pediatric dermatologist, most of the infections we're going to see in the clinic are superficial mycoses, which affect the outermost layers of the skin and hair, but we will also see ones, cutaneous mycoses, which extend down into the hair and nails and not just affect the epidermis. If you do work in a hospital setting, you may see subcutaneous mycoses, which involve the dermis, the fat, the muscle, and the fascia. And then those can progress to systemic mycoses due to a primary pathogen, which usually originates in the lungs or sinuses, and then transfers to other organs. And it's usually a dimorphic fungus that causes that. Now, systemic infections are usually only found in opportunistic settings with an immunocompromised host. And again, you won't see those unless you work in an academic inpatient setting. So what is a dermatophyte? It is an imperfect fungus. No offense to the fungus. You're not imperfect, but you are. It has asexual reproduction only. There's 40 species and 3 genres, the trichophyton, epidermophyton, and microsporum. And the word dermatophyte is Greek for the word skin plants, and it causes infection of the skin, hair, and nails known as tinea. And it obtains its nutrients from the keratinized material in the skin, hair, and nails. And just to put it out there, not all annular skin lesions are tinea. And you can look around here and I will tell you that these are not tinea. So again, not all annular skin lesions are tinea, and not all hair issues that lead to a red scaly scalp and hair loss are tinea capitis. So again, all of these things are not tinea capitis. And again, not all nail changes are going to be onychomycosis. So all of these skin conditions are different conditions that you may see that are not due to fungus. But sometimes we will see annular lesions, we will see hair loss, and we will see nail changes, and they will be fungal. Like all of these pictures here were all due to fungal infection of the skin, hair, and nails. So the diagnosis may not always be clear clinically even for a pediatric dermatologist, I've missed fungus on both sides of the coin. I've missed it where I did not diagnose it, and I missed it when I overdiagnosed it and called something that was fungus not fungus, that wasn't actually fungus. So I think it's really important to be humble when you're looking at the skin and realize that you're not always going to be right. So other things that you can do to help your clinical acumen in making the correct diagnosis is basically, palpate the skin, feel it, to see if it's just a superficial infection. So again, our hands are our best tools as a dermatologist. So again, definitely palpate the lesion. Also check for lymphadenopathy. So really, if you have a scaly scalp and lymphadenopathy, the risk of it being a fungal infection really go up significantly. So again, if you palpate any lymphadenopathy, you can move fungus up the list on the diagnostic differential diagnosis. And then also do a KOH. KOHs are super easy. I think we've gotten away from doing bedside tests. And as a dermatologist, I think bedside tests are something that differentiate us from the masses. So, just scrape the skin, get some skin flakes, certainly at the advancing edge of an annular lesion, because that's where the fungus will be. And then look at that under the microscope. And then this is a word of advice from someone that has learned the hard way. Always take a culture. It's easy to do a culture. It doesn't hurt. It's inexpensive, and it gives you invaluable information, both positive or negative. And especially if you plan to treat empirically, please do a culture before you give treatment. So it is so simple. Again, it doesn't hurt, and it only takes about 30 seconds. All you have to do is get your little Culturette tube, dip it in the media, get it a little wet, run it through the scalp, run it over the skin lesion, and then put it in the tube and send it off to your good friends in the lab so that they can run a culture for you. Again, it may take 6 to 8 weeks, but again, if you are going to start treatment because you're leaning one way or the other, then when they come back, if they're not better, you'll have that information at their follow-up in 6 to 8 weeks. So again, no excuses. Always take a culture. And again, this is another one of the pearls that I really like to share because I think it is so, so important. Never use a combination topical product, or you just won't know what you're treating. And that's just not a sign of a good physician. So again, never use a combination topical product because it not only makes you look dumb, but it also limits the amount of clinical information you can get back from the patient when they're coming in for follow-up. So again, I always, do a KOH if I feel like it needs to be treated empirically, either because the patient is uncomfortable or the parents are really concerned. Choose either a pure topical steroid or an antifungal agent based on which direction you're leaning clinically after you take a KOH, but do so after you take a culture. And then again, when they come in, if they've had non-response to the treatment you've prescribed, that can be a diagnostic test too. So if you thought it was fungus and you gave an antifungal, it's not better, it may not be fungus. So again, please, please, please always take a culture, never use a combination product. All right, so again, simple, low-tech bedside tests, very easy. Go into the basics here, KOH skin scraping. Basically, it just requires you to have some point of service testing credentials, which most hospitals do, most clinics do. All you really need is a slide, a cover slip, and then another slide or a 15 blade, potassium hydroxide, and a microscope. And for a kiddo, if it's really scaly, I don't even like to use a blade. I will take the one slide and I'll use the other slide, and I'll use the slide to get the skin flakes onto the microscope slide that I'm going to use. Again, add your potassium hydroxide to collect that, add the potassium hydroxide after you put your cover slip, and I like to do that. So again, you're going to scrape at the edge of the lesion. You're going to use either your blade or another slide, you're going to collect the scale. And then basically what you're going to do is put your cover slip down and then let the KOH infuse underneath your cover slip. And that's the best way to get a KOH that doesn't have a lot of bubbles. And then you can heat that gently to help break down the skin cells so you can see the fungus best. If you can go in and see another patient and then come back and look at that, you'll actually increase the odds of being able to see the fungus or the hyphal elements. And again, fungal culture, grab a standard culture tube, wet the tip. I like to just put it in the media and squeeze it on there a little bit, then rub the affected lesion. I go throughout the scalp. And then you can scrape some scale using a slide or a blade to put that in the tube. You can also pull a hair or two in an area that you see that's infected or involved and include that in the tube. And then as well, you can do nail clippings and they can be sent for culture and PAS as well. And Sages does accept those specimens. So again, you can do that with using a curette, a paper clip, a slide, or you can do a blade to get that debris out. And then you just simply clip the nail. So again, simple, easy, low-tech bedside tests that don't hurt and give invaluable clinical information. So let's jump into our cases. We're going to go over 4 cases. This case is one that you may see in the outpatient clinic. You will see in the outpatient clinic. You may even see it in your own home or your friends' kiddos at a sporting event. So again, case 1, 16-year-old male teen. He was an avid athlete. He developed this rash on his back. It had spread to his chest. It was mildly itchy. They had been putting hydrocortisone on it, thinking it was eczema, got worse. And the teammate that he is best friends with also had a similar rash, and they worked out often together. So this is Malassezia fervor. Tinea versicolor is the clinical name, or Pityrosporum versicolor. And this is a KOH prep. It's pretty classic. It shows the spaghetti and meatballs underneath the microscope here. And then this is, of course, a punch biopsy that shows it in the superficial horn here. So again, your spaghetti and meatballs. So treatment of tinea versicolor, I like to use topical ketoconazole with shampoo as a body wash. You can use a cream, and I just have them use the ketoconazole kind of as an everyday treatment when they have an active infection, and then just once a week as a body wash in the shower. You do have to tell them that the hypopigmentation will persist after the treatment of the active infection, and they just need to wait for that to improve. You can also use topical clotrimazole or miconazole cream, and then there are oral agents. So ketoconazole or fluconazole. You can see fluconazole is significantly more efficacious in treating this infection. And then also just wanted to put this out, and I know many of you know this already because it's been out for a while, since August of 2013, but the FDA did announce that clinicians should no longer prescribe oral ketoconazole is a first-line therapy for fungal infections because of the risk of severe liver injury, adrenal insufficiency, and adverse drug reactions. So again, not only is fluconazole more effective orally for this condition, it is also safer. So again, that should be your first-line therapy if you're going to treat orally, if it's extensive. But typically, I try to use the topical treatments in this condition. All right, other skin conditions with Malassezia. So you can see here, this baby has got what looks like classic seborrheic dermatitis, and affecting the hairline as well as the eyebrows. Same thing here in the ear crease. So again, Malassezia is a common finding there. Here, when you see this kind of stuck on scale, Malassezia is probably playing a significant role. So it's important to add in a topical antifungal along with a keratolytic like a salicylic acid. So nizoral shampoo with a topical salicylic acid shampoo as a combination is very effective in this condition. And then you can see CARP here, confluent and reticulated papillomatosis. This is Pityrosporum folliculitis, and I see this really commonly in kids that are on treatment for acne when they're on oral antibiotics. And again, hopefully we're being good stewards of antibiotics and not using a whole lot of antibiotics in acne, or not for long term. But in the past, when acne patients were treated long term with antibiotics, I would see them get Pityrosporum folliculitis quite commonly. And then neonatal cephalic pustulosis is another condition that little babies can get in those first few weeks of life, with a significant inflammatory response to malassezia. So again, these are things that you will see in clinic, especially if you do pediatric dermatology. So be on the lookout for those, and know what they are and treat appropriately. Now moving into some cases as far as significant infections with systemic malassezia. So skin colonization is pretty common with this in NICU infants. And it is part of the normal skin flora. Now, catheters can become infected, unfortunately, as well as the connecting port. And patients that are sick can get fungusemia and sepsis. And again, it's most common in infants receiving parenteral nutrition with lipid emulsions. So you do have to have a high index of clinical suspicion. This is difficult to grow in culture. You can see it in whole blood smears. You can do molecular tests for it. And again, you have to have a really high index of suspicion for this. And basically, antifungals aren't really going to help you. You really have to remove the catheter and stop the lipid infusion. So again, things that you will likely not see, but if you are a resident on an inpatient service covering the pediatric consults, especially those in the NICU, you may see this and need to have a high index of clinical suspicion. And usually they do have some clinical cutaneous sign around the tip of the port and the catheter here. So case 2, again, this is going to be a more common finding if you're doing the inpatient pediatric dermatology consultations. Case 2 was born to a 25-year-old mother who was unresponsive to tocolysis at 24 weeks gestation. She gave a vaginal birth to a 610-gram baby with APGARs of 2, 6, and 8. The patient was hypotensive, neutropenic, and the chest X-ray was consistent with infection and or edema, and then had severe cutaneous excoriation, and I would call it ulceration, but excoriation is sometimes how it is described. Patient had worsening metabolic acidosis with hypotension and died on day of life 4. And this is what the cutaneous findings were of that sweet baby who did not make it. This was the findings of the punch biopsy here. And you can see that it is quite obvious that it is an infection. This shows the candidal infection of the cord and what the placental findings look like under the microscope, what was found in culture. And of course, this was a diagnosis of congenital candidiasis, quite extensive in the first case, but this is a more typical presentation here in this photo here of these kind of very friable superficial pustules that do like skin folds. So 10 to 35% of pregnant women will have candidal colonization. Most will be asymptomatic. And then 50% of exposed infants will be colonized. Only 10% will go on to have systemic disease. It is increased in women with cervical foreign bodies like cerclage. The baby will be affected 1 to 4.5% of babies that are less than 1,000 grams will have significant infection from this ascending infection that typically involves the skin, the lungs, and the GI tract. So congenital candidiasis mucocutaneously will present with papules, can present with pustules that do involve the hands, the head, the palms, and the soles. They're erythematous macules that lead to scaling, and then they get this burn-like dermatitis that's been referred to as excoriations in the literature, and then also progress to erosions. It can affect the perineal area in term babies, and that is usually self-limited. And then thrush is uncommon in congenital candidiasis. Then when it becomes more disseminated, then it can progress with a mortality of 40%. And again, most of those babies are going to present with mucocutaneous candidiasis, but the ones we have to worry about are the ones that are really small, the babies that are in the NICU. So again, high mortality for disseminated disease, but again, in patients that we're going to see in the outpatient clinic, most of them are going to be term babies, and the conditions are going to be self-limited or easily responsive to treatment. All right, case 3. This is a 13-year-old male. He had relapsed T-cell leukemia. He was on high-dose chemotherapy, had an ANC of 0 with persistent fevers, scalp lesions for a week. They were initially thought by the primary team to be folliculitis. Dermatology was then consulted and a skin biopsy was performed. And you can see the biopsy sign here of this scaly lesion on the superior top of the scalp. This was a inflammatory kind of plaque almost that was firm to the touch and had this central necrotic eschar. And this was progression of a lesion on the scalp over time. And fortunately, the skin biopsy did help make the diagnosis. So techniques for biopsy, you just want to use a punch biopsy with clean procedure, and then just place simple sutures. It's best to biopsy at the edge of a lesion, not in the center. So you want to get on the edge of the tissue where the tissue is viable, because if you get into that necrotic tissue, you're going to have a negative culture. And the media is important, so you don't want to put this into H&E if you're going to be sending it for cultures. So again, sometimes you can bisect your lesion and send part for H&E, but you do want to use media. And you can just put that on fresh saline soap gauze if you don't have the appropriate media. And then again, send that for histopathology with special stains and cultures, which can be done by our friends at Sage's Diagnostics. All right, so here is a photo of the scalp biopsy, and you can see here the special stain is diagnostic for Aspergillus niger, and this is a picture of the culture with rapid growth over 1 to 2 days. It's a pigmented black colony, and it has a completely covered head here, as you can see in the illustration and also the photomicrograph. And you can see the fruiting heads as well, which you can see in the lung cavity in disseminated disease. You'll also see a nodule produce oxalate crystals. And then again, in your immunocompromised patients who are going to be more prone to aspergillosis, they'll have the cutaneous findings. The primary is usually injury, burns, or you can see them in neonates. And then you can have hematogenous and embolic spread from other organs, including the lungs, the sinuses, the central nervous system. Certainly it can become disseminated. And then our last case, case 4, this is a 14-year-old Hispanic male with end-stage renal disease due to focal segmental glomerular sclerosis. He had had bilateral nephrectomies for control of his hypertension. He was on peritoneal dialysis until he was accepted for renal transplant. He was readmitted to TCH 1 month later with a lesion on his forearm and hand, and his WBC count was 2.8. A biopsy with histopathology and culture was done. You can see the skin lesion here, and then what it progressed to after it was debrided. So histopathologic identification of fungal species can be difficult. It's very important to have a dermatopathologist look at this because it does look very different under the microscope. It can be aseptic, posiseptic. The branching pattern can also be difficult to evaluate in 2 dimensions. And the hyphae can be scant, they can be folded, they can be kinked, they can be fragmented, and difficult to assess. And then prior treatment will affect it, and then tissue necrosis will also affect it. So it is important to have a dermatopathologist you can trust looking at these slides for you to help you make the diagnosis. So here you can see yeast with the true hyphae, and then also what pseudo hyphae look like. Here you can see the septate versus the aseptate varieties here. And then the difference between mucormycosis and aspergillosis. And then certainly special stains. Silver is a non-specific stain. It facilitates detection of fungal elements, and it allows for organisms to be roughly classified, and with, a 79% correct identification based on special stains. And then again, you can see here collagen fibers, bacteria, and melanin will stain, but it is non-specific. And then again, tissue necrosis or treatment will affect what the fungus looks like. They can be swollen and not necessarily look like what you would be expecting. So again, really important to involve your dermatopathologist to help with the clinical pathologic correlation. Also important to give your pathologist the clinical information if it's been treated. And then again, you want to biopsy again in the right areas. You got to be biopsying viable tissue to be sending for H&E, special stains and cultures. And again, here you'll see the aseptic fungi that look ribbon-like. And that is, again, important to know when they're doing PASs and silver stains so that your pathologist can help you make the correct diagnosis. So mucormycosis, zygomycosis, phycomycosis, again, not very good at pronouncing words, but again, luckily these are things we don't see often in the outpatient clinic, but are important for your board. So again, these are contaminants, they're opportunistic. A lot of times you will see these things in culture in an immuno compromised person, and those are definitely should send off alarm bells. But in an immunocompetent person, a lot of times they're just a contaminant in your fungal culture. These are saprophytic. They grow in decaying organic matter such as soil. They can be airborne, so they can get on the scalp of a child, especially those with atopic dermatitis, when they're scratching a lot. So again, clinical pathologic correlation is very important. And here you can see mucor and rhizopus and what they look like depicted and in photomicrographic form. And then again, luckily we're not going to see these often, but the invasive zygomycoses can affect the skin, more common in trauma, surgeries, and burns. Can also happen if patients have arm boards with adhesives. So again, keep that high clinical index of suspicion if you are on the inpatient services doing consults. You can have rhinocerebral, pulmonary, gastrointestinal, and then certainly disseminated. And sometimes a dermatologist is the one that actually helps the team make a diagnosis. So don't underestimate the impact we can have as dermatologists dermatologists in the inpatient setting. For those of you out there living in that world, and thank you for those who are out there doing it. Because these are hard conditions, and it's definitely taking a multiple team approach with involvement of ID and the primary service a lot of times, which includes oncology. But again, don't discount the role we can play as dermatologists in helping make the diagnosis and get the patient the right treatment. So that ends our talk with the fungus among us. And I hope you've enjoyed it. I hope you've learned a few things and you go out and apply your knowledge and can put these together and figure out what goes with what. And if you send in your answers, you may get a special prize. So go out there, be good dermatologists with all this knowledge you've learned on T4 and help those patients who have fungus among us. Have a good night, y'all. And again, story time with Dr. Bree launching this week. Send your patients to our YouTube channel for Made a Masterpiece. Thanks.